Thank you all for this beautiful July Rhode Island Day. I'd like to call the July meeting of the Rhode Island Opioid Settlement Advisory Committee to order. And the first thing we'll do this afternoon is go around the room and do a quick introduction of the committee members and EOHH staff. So Katie, why don't we start with you and go this way this time?
Hi, my name is Katie Hansen. I am currently Director of Outpatient Treatment Services at Thrive Behavioral Health, and I am a person in long-term recovery and an expert on this committee.
Hi, Adi Goldstein, Deputy Attorney General, here for the Attorney General, Peter Navarro.
Jeffrey Rome, the Fire Chief in the town of West Warwick, and I'm the Kent County Representative on the board.
Deputy Speaker, House Representative Designate.
Maria Santos, Representative Providence County.
Jake Bazillion, representing the Senate.
Nico Lincoln, Director of Reentry Services at the Amos House and the Community Representative.
Bob Donnelly, the Fire Chief of the City of Newport, representing Newport County.
I'm Julie Hamill, I'm the State Court Administrator, and I serve as the Chief Justice's designee.
Bill Chin, one of the medical directors at the Rhode Island Department of Health.
Jerry Larkin, Director of the Rhode Island Department of Health. I apologize, I have to leave a little before 2. Dr. Chan is my longtime designee, permanent designee.
Good afternoon, everybody. Rich LeClaire, Director of BHDDH.
Samantha Benenda, Community Representative, CPRS, CCHW, Parent Support Network, and CCA.
Well, let's go to the state staff. Michelle.
I am Michelle Goncalo, the Finance Manager for opioid funding at OHHS.
Christina Schultz, also at OHHS, I serve as the lead analyst for the task force. Cameron Berman, Program Evaluator.
Hey, Kathy.
I'm Kathy Schultz, the Director of the Governor's Overdose Task Force, and also I work at the Executive Office of Health and Human Services, and I work with the team here.
Thank you all, and my name is Brandon Marshall. I'm have the pleasure to serve as chair of the OSAC committee, and I'm also a professor of epidemiology at the Brown University School of Public Health. Let's do one more introduction and we can get started.
Good afternoon, everyone. Sean Lacey, Town Manager, Westwood.
Perfect. Thank you. Welcome, Sean. All right. As our first order of business, I'd like to get approval of last month's minutes. Can I get a motion to approve those minutes if you've had a chance to review them? Danny, a second? Second. Great. All in favor of approving those minutes?
Aye.
Any opposed? Any abstained? Great. That motion passes. Okay, let's go to today's agenda, if you will, still. We've got a lot to get through, so I'm going to keep us moving. We are going to be focusing today on reviewing the allocations and spending so far, and then we have a proposal for you for fiscal year 2027, which is Kathy will go into some of the state processes to bring us to these proposals. Michelle will review the budgetary expenditures to date. I also have some information on supplementation for you, which I'll get to in a moment. So that is the plan for this afternoon. All right, so let's go to the next slide still, and we can go along to slide 5. So I just wanted to review some of our key principles for guiding our decisions around recommendations for OSAC funding. When this committee was constituted in 2022, the members endorsed the Johns Hopkins principles for decision-making around opioid settlement funding, which are shown on the next slide. There are 5 principles that were promulgated in that document, which we and many other states have adopted. They are shown on the top 5 there. And then the committee at that time added a 6th principle around sustainability. So we should be thinking about these things when we're making our recommendations. I won't repeat everything on this slide, but suffice to say that first principle involves spending money to save lives, and that focuses on supplantation as well, which we'll talk about in a moment. Using evidence to guide spending, investing in youth prevention, ensuring a focus on racial equity, which I'll talk more about in a moment, and also conducting our business in a fair and transparent process and in a way that engages people with lived experience, community leaders, members of the public, and other key groups. And finally, the principle that we added was focused on thinking about sustainability as we're making decisions around recommendations. So that should be review for most of you, but I just wanted to go through it with a few new members on the committee. We go to the next slide, so. So just to focus and narrow down a little bit more on racial equity, last year the committee developed and endorsed this path forward to actually operationalize how we think about racial ethnic equity on the committee. There are 5 domains there. It is also printed for you in your information packet so you can review it later. We focus on transparency, including presentation of data broken down by race ethnicity to guide our recommendations. The state has developed an equity-focused recommendation process, which includes training of committee members and inclusion of equity impact statements in all of the procurements that go out. The procurement processes are designed to be equitable as well through mechanisms shown in that yellow box on the slide. And there's also a focus on community-based capacity building. We provide indirect rate support to all beneficiaries of the opioid settlement funding, and they are mandated to develop equity work plans in all contracts and report on their progress. And finally, we all hold ourselves to shared communication, including use of plain language and clear communications. So that's our second set of principles that we adhere to. And the final one I wanted to introduce before I talk about supplementation is my favorite slide, which is the continuum of care. So this is the way that I actually personally like to think about how we allocate opioid settlement spending, which is to use the funds to try to move Rhode Islanders along the continuum of care. So for example, the committee has recognized that social determinants of health, things like housing, are foundational to support health and well-being of all Rhode Islanders. We invest in harm reduction and rescue efforts because we know they're life-saving and because they help serve as a critical bridge to move people along to the next stage in the continuum of care. We have used opioid settlement fundings to expand and improve the state's treatment infrastructure and develop new novel strategies to address stimulant use disorder, for example. And finally, we use opioid settlement funding to support people who identify as being in recovery to ensure that they can achieve health and well-being throughout the life course. And finally, all of this is undergirded with investments in prevention, which over the long term are designed to reduce the number of Rhode Islanders at risk for overdose and addiction in the first place. So we make allocations according to each stage of this continuum of care. All right, before I hand it over to Kathy and we open up for discussions, I just wanted to come back to a topic that we brought up at our last meeting, which was on supplantation. So if you go to the next slide, Sil. This is an issue that was raised by Kristen Pendergrass, one of our guest speakers from the June meeting, I think, or maybe May? May. She recommended we start thinking about this. So we did some research. A number of states have developed guidance or legislation around supplantation. One that I liked in particular was Colorado. So you have in your packet Colorado's guidance in front of you. And I just wanted to summarize their definition of supplantation on the slide for us to think about. The other resource that we found and we wanted to circulate to you was a Network for Public Health Law guidance on supplantation that reviews where many states are in terms of thinking about this issue. My thought that I wanted to propose to you today, but would love feedback on this, is that this is something that we could revisit after more consideration in the fall. It's certainly not urgent, but the recommendation is to develop, with your input, guidelines or restrictions around supplantation. Today, I just wanted to introduce the topic and then return to it later in September or October. So what is supplantation? This is Colorado's definition. Basically, it is the use of opioid settlement funding to replace an existing funding line to basically free up that funding to use elsewhere. So for example, if a state were to have supported a jail-based MOUD program in their correctional system, and they use opioid settlement funding to replace that funding, and then use that existing amount of money to support road repairs, that would be supplantation. What is not supplantation is to expand an existing program, to enhance capacity of an existing program, or to basically continue a program that would have otherwise ended because that funding has been terminated. So that's the thinking around supplantation. As you can read in the documents, many states have clear guidance that restricts the use of opioid settlement funding for supplantation. Rhode Island has in its settlement language that the funds should be used for forward-looking opioid abatement programs. So that's noted in this guidance. That's what we have currently. But Kathy and I thought it might be helpful to get some initial thoughts on this and come back to you maybe in the fall where we could actually vote on our own guidance around supplantation. One option is to simply adopt the Colorado guidance if we like it, or modify this or develop some other guidance around supplantation. Kathy, did I miss anything, or maybe we could open it up for discussion? Perfect. All right. So let's pause here. Any questions or thoughts from the committee? Do you like the idea of coming back to this in the fall once you've had some time to think about it? Any initial thoughts on the Colorado definition? The floor is yours. Yeah, Adi, thank you. I thought you jumped in.
I'm always there. I'm always there for you.
Yeah.
Yeah, look, I think it's a great idea, and that's certainly the intent. And I think that has always been the intent from the get-go, that this is a way that we should use these funds. And with federal grants, as folks are probably familiar, federal grants often have a non-supplantation as a requirement and a condition to those grants. So states, when they apply for certain federal funding, they have to essentially certify that it's not going to supplant state spending. But this is really an issue for the General Assembly, I think. This is something, these funds are allocated through the budget process, as are other funding streams. And so I really think it's a budgetary decision for the General Assembly. And, maybe this is something the committee ought to talk about or eohhs can propose as, whether it's in legislation or part of the budget submission next year for a non-supplantation clause. But we've got members of the General Assembly here, maybe their views on it.
Probably the safest way to go. I agree with you, that we make sure that the approval is where it needs to be, and then comes back to where we want it to be. I agree with you.
We're just wondering if we have faced or are being faced with instances where this is going to be an issue in our decision-making, or is this more preventative so that we're all clear on the rules, or are we facing some threat about this happening in the near future by whatever process we're using?
Good question, Michelle, or Kathy, feel free to jump in, but my understanding is this is preventive. We've had no evidence that this is happening already. It was something that our presenter raised and encouraged us to think about, so that's why we're bringing it to you, but I'm not aware of this being an issue currently. Yeah.
Okay.
Yeah, Director.
So I guess I'm wondering if there's a little bit of light here between supplantation, diversion would be an easier word to say anyway, of funds that are allocated to address the opioid epidemic versus funds that are being used for some other purpose by the state. So let me illustrate what I'm talking about. So Is it supplantation if the state is funding, naloxone kits? And the state no longer funds those naloxone kits and we use settlement money. That's not supplantation, correct?
My understanding based on the guidance.
Because it would be ending, right?
Yeah, it depends on sort of the what if, right? So if that funding that had been used to support the naloxone program were repurposed for other means, that would be supplantation. If that existing funding to support the naloxone program were being terminated or going away, and we used opioid settlement funds to continue that work, that would not be supplantation. So that's my understanding, is it depends on the.
I don't think, how do you track the dollars that closely then? They're not labeled. So if, the budget gets created once a year.
Yeah.
And the state decides to not fund an activity related to the opioid epidemic, but they fund something else, you can't sort of say, well, they divert, they took the money that they were going to use for the opioid epidemic and they used it to, build a playground. You wouldn't be able to track that in that way.
I can't say that I track everything. Well, Michelle and I do track a lot, and we do work with the state agencies. And so, and again, I want to just be clear that I don't know every single thing that's happening in the state budget, but the restricted receipt accounts, which is settlement and stewardship, we do. We work with the Department of Corrections, BHTDH, and the Department of Health. So if there's a reduction in some way, we work together to try to see what is infrastructure, what needs to be sustained, and so on and so forth. If there is a line item, I'll use as an example, which I'm not an expert on completely in the depths of it. Michelle and I work with the Department of Corrections. Because there is a budget line item for the Department of Corrections specifically for medicated assisted treatment programs, I believe it is, and it could be sort of wrong on exactly what it is. If that, for instance, was no longer in the budget, because that is not an oversight of eohhs, then that would be a conversation we would have with the Department of Corrections. I can't answer whether that's supplantation, because it could be if they went to move that money to go somewhere else. I don't know the answer. I actually would defer to legal counsel, if anybody knows, or the General Assembly.
You hit it, and it's accountability in who actually has control of the money.
Yes.
That's what it basically comes down to, since you get allocated under your funding now, and then when you start to move it.
Yes.
That's where, and it needs to be clarified, and I believe it should be clarified in the General Assembly.
But it almost seems like you'd have to be able to speak to motive, which I don't know how you can do that. And that supplantation, diversion, in this definition seems to me to be only if you take the settlement money and say, use it for something that is completely unrelated, build a playground. Maybe you could argue that playground's related to the opioid epidemic, but probably not. So that's what supplantation is. So there is some kind of, space to use the money, although, again, the reference to forward-looking programs would suggest otherwise, I think, if that's what the intention was. You could say, oh, the state no longer has the money for X activity related to the opioid epidemic. We are now going to use settlement money in order to continue that program. Yes, that's not supplantation.
Right.
Yep.
Okay.
That's right. That's my understanding. Yeah.
I have a question.
Yes.
I'm concerned. Would there be an opportunity for this committee or maybe the General Assembly to create limits? Because it can go on in perpetuity, if you get what I mean. If this supplantation begins to become something that's annually done each time the budget comes out through each year, it becomes growing more and more that the supplantation, I think is the word, begins to take place. And, as we see needs or programs getting cut, whether the United States government begins to start, cutting funds like I think they're doing to states, where we start supplanting these different programs with opioid settlement, and those programs aren't actually, saving lives, if you get what I mean. The example you gave is the Rhode like repairing roads, if we begin to take opioid settlement money and supplant the existing funds that was taken away for some reason and start using opioid settlement money for that, is that supplantation? And do we have the ability to create limits if that is such? If you get my question.
I think that's the goal, right? That's the thought, but it sounds like maybe that ultimately sits with the General Assembly. Perhaps this committee could create guidance to.
Even just goals.
Goals.
I mean, not to
Yeah.
interrupt, but I think really what the stated goal here should be, I mean, it's only my second meeting, but, with the unique budget pressures that are happening at the federal level, even at the state level, as we saw before administrative changes, like, these funds shouldn't be able to be scooped, presumably, to fill budget holes that may arise because of general revenue or, federal pass-through changes. And I think that's what we're trying to prevent. And there are plenty of different ways that funds can get braided at the state policy level that would have, we did that with pandemic recovery funds. So I think having some sort of outwardly stated goal and probably legislation prohibiting that scoop practice would be a way to protect the integrity of these funds.
Adi, and then Dr. Chan. Yeah.
So I think we just need to be clear about our use of language and what we're talking about different things. And I don't think you meant this, Senator, but just to be clear, settlement funds cannot be scooped for other things. They are governed by court order and they must and can only be used for the purposes allowed by the court order. So they must be used for abatement purposes. So those funds, and that's why I don't think you meant that, but I just, hearing the word scoop makes me nervous.
But let me ask you a hypothetical.
But they cannot.
So what if we have an existing program, right?
Yeah.
We use a DOC program as an example, the general revenue support, right? We have general revenue pressure. We don't have enough general revenues to continue supporting the program.
Right.
Can we use opioid settlement funds to continue that program?
Right, so that's actually, I think, the crux.
Right,
Exactly, that is the crux of what we're talking about.
What does this group think we should be able to do?
Right, so I think that, so there are like really two issues there. One is ultimately, I think, a General Assembly issue. That's what I was saying before. So if, I think examples kind of work best, right? That there is a, maybe it's not a great example, but there is a treatment facility out there. And that treatment facility has received some federal funding in the past year after year, and that treatment facility also receives settlement funds for its program. General Assembly decides next year we're no longer funding this through our general revenue or whatever. And so one way to think about supplanting is, well, okay, now the General Assembly took away that money, is it going to be supplanting to fill that in with settlement funds? I mean, maybe, but the answer is, okay, so what? If we want this treatment facility to continue to operate, and that's an important goal for us to do, then I guess we should allow it. Of course, I think what the committee here is talking about is creating guidelines that would discourage that kind of activity from by the General Assembly.
Supplantation.
Right, because.
Is when the scooping starts. I mean, that's what will happen. I've been at those negotiations. I know exactly what happens.
And then you're really undoing the purpose of these funds, and you're undoing, frankly, a lot of the progress that's been made in increasing funding in this area. But we all live also in the real world, and sometimes needs change, emergencies arise, priorities change. So these are difficult decisions. I don't think any of us can presume to be making them right here, but that is a problem.
Supplementation is the second that millions of dollars go out the door.
Kathy, and then I do want to move us along, so we can come back to this.
But I also think there's a third issue of supplementation, just to be really clear, which is the one that is easier to govern and the one that is a granting agency, or if it's eohhs governs, which is, okay, treatment house themselves gets, that line item remains in the General Assembly. But for whatever reason, the treatment house decides, it's too hard for me to get the funding I always got from the General Assembly. So I'm just, or I'm going to shift monies around in different ways, and I'm now going to ask for additional settlement funding or use settlement funding for purposes that were previously funded or that I previously received funding for. So the entities that are receiving money from this program also can't use it to supplant funding that they could get, or they would be eligible to get or could get otherwise that they've previously gotten. That's kind of the easiest thing to, I think, police.
No, I hear you, Dave, but I would say we'd want to discourage any sort of,
100%.
anything that opens the door for supplementation,
Totally.
knowing how the General Assembly works.
Yeah. Kathy, do you want to speak to the animal?
You know, honestly, the next section is going to answer some of those questions. So if anybody else has anything else, and when you're ready to move forward, I think this might help answer some of the questions that you're all discussing right now.
Right.
Because
There is a lot of oversight.
yes, there's a lot of, there's
Activities.
processes in place. And I'll kind of, and I'm sure you will too, we'll talk about what this body's responsibility is and how the agencies actually procure and make decisions on programs.
That's great. Dr. Chen, do you have one comment and then I'll move us along?
Yeah, one quick comment and question. In normal times, we don't certainly agree with this, and I think in general, we trust the General Assembly to make the right decisions. I'm a little bit nervous about the federal stuff because I think the feds are making decisions abruptly, and we may eventually have to fill some holes or continue some programs that the feds say this no longer aligns with our priorities. So I would just want to make sure whatever we do doesn't sort of tie us into a knot where we couldn't do that, which would be totally outside of any of our control.
Great.
On the safe side,
Agreed.
the General Assembly is where it's at, and you have to work within that frame. So we don't wanna not, or to understand that it will have to work within it so that we're safe.
Got it.
And we're doing what's right.
That makes sense. Thank you all. This has been very helpful for us. We'll mull this over and we'll bring this up again in the fall. And I encourage you to read the guidance in terms of what other states have done as well, which is helpful. Okay, just due to time, I'm going to move us along and then we'll go to our first public comment period. So over to Kathy, who's going to take us through the state's process for developing the guideline, the proposal that we'll have for you a bit later in the meeting.
Right.
Go ahead, Kathy.
So and that's why I said it would make sense. You can move to the next slide. So I want to show everybody that there is a whole of government approach, governance structure that's in place. This is for all things overdose, and it's not just opioid overdose, it's all things overdose, because I want to bring us broad and then kind of bring us in. And so that is why when I talk about the task force, it's because it's really the central place that's been around for so long, and where it's the advisory for a lot of the planning. We have two of the co-chairs of the Governor's Overdose Task Force at this table. So we talk and we meet on a regular basis. So I'm going to start with level one. We actually had our meeting this morning and we smiled and laughed, and I try to make our directors feel like a breath of fresh air. I'm just teasing. I always try to make a joke out of things, but we did say these things. And so we meet on a biweekly basis and we talk about overdose specifically. So it's not always just opioid overdose. It's not always the opioid settlement committee. It could be about the task force. It could be about federal policies. And we have these broader conversations and we talk. It's a 30-minute meeting and I bring, some of the things or the agendas that are coming up, and we talk about the strategy around, what's happening in the state. We also bring in some of our ad hoc agencies such as DCYF, the Department of Corrections, Department of Housing. We haven't really had to do this too much in that level one meeting, but I'll give you an example of an ad hoc meeting, and that was the Overdose Prevention Center. When we were talking about the Overdose Prevention Center, the Department of Health regulates it. eohhs has the contract, which is opioid settlement funded. We knew that we needed to bring DCYF in that conversation because there were some questions around youth. And so that's an example of how we use our government structure as a whole of government, and we communicate with one another. And then we have our interagency teams, and these are like eohhs, including Medicaid. This is level 2. This is division director level of each of the agencies. It's normally the core agent. It's always the core agencies, which is the HTDH, the Department of Health, DOC is considered to be one of those core agencies. But we expand beyond that. We also have Rhode at this meeting. We have the Department of Housing at these meetings. And we meet again on a bi-monthly basis. And we meet to talk about strategies, really take a look at kind of what is happening. Then we have our agency core meetings. This is where it's very much about the settlement and stewardship, and Michelle is actually going to present a little bit of where we are with the budget in a couple of minutes. Michelle and I co-chair those, or co-facilitate those conversations, and what we do is we bring the agencies that are receiving opioid settlement and opioid stewardship funds together on a monthly basis. We bring finance, we bring the programs, and we have a discussion, and we look line for line at each of the budget items. There is also, and it's on the next slide, there's also a funding request process. So I'm going to wait for that, but that kind of will answer some of what we were talking about, that this is all being really looked at. And then we have our core function convening. And that is like emerging issues, planning, and so on. So that could be like internal, and then we kind of come together, there's something bubbling up and we need to talk about it. It's not on here, but I want to also mention that we have an overdose data council. Chris Schultz, Dr. Schultz, I love saying Dr. Schultz because I get to steal that. I didn't have to go get my PhD to share it. She actually is the chair of that, and we have an interagency small data council that plans for the more public-facing overdose data council. And so that is also happening to look at the indicators across all of the strategies, not so much on a programmatic level, but if that is needed, because we're seeing there's something going on with a program, we will bring that information there. So I'm going to move on to the next slide. It's a lot of information, but if somebody wants a clarification before I move on, please let me know. Okay. So this is kind of sort of the more details of that. And believe me, the details behind the scenes is much more than this. I tried to broaden it out as much as possible. So the impact and performance monitoring, that's kind of that overdose data council that I was talking about. It's those monthly meetings that we have with each of the agencies. We look at the funding, the spending, and like if a program, for instance, there was an issue with the program or the agency or the organization, that's where we'll have that initial discussion and usually have a breakout conversation about that. And then in the strategic financing, and this is the dates, this is the timeline of like where that, like during the times that happens, it aligns with the state budget. It also aligns with like the calendar year as far as the Governor's Overdose Task Force calendar, and also the calendars that we try to agree to and set up here for the Opioid Settlement Committee. And then we do funding projections, and the state agencies that are receiving state settlement and stewardship, but mostly settlement funds, they get these massive spreadsheets, and I ask them every year during this period of time to fill this out for programmatic updates. And Michelle could explain more on this. Michelle, actually, it's a requirement of OMB that they have to give projections of what they think that they will spend for that fiscal year. And then we have our interagency review of revenue, budget, sustainability, and it's just a process that it took some time to create, but we have this and we make sure, and everybody in all the agencies as well as eohhs, we kind of know what to expect as we go along. I think it's really important that it may not say this in here specifically, but we also have a funding request process that was created a couple of years ago in response to some of the questions here in the Opioid Settlement Committee. Anytime one of the state agencies is looking to make any changes in amounts or funding within the pillar, because remember, when you all vote, you vote on the percentage of the pillar. We ask that a request, so that it can be documented, is sent over by the agency. It's reviewed by the assistant secretary. Usually, if it's within the pillar, it's fine. It can just, the assistant secretary will make that determination. I'll give an example. Something's not being spent, and it's kind of money that's available, and then there's a need in another program. It's on a like vendor program level. That request will come in, and then it'll be reviewed. And in there, they have to show that it's allowable use under the settlement agreement and that it aligns with the strategic plan. If for some reason, just so you all know, if somebody said, we want to move money from treatment to recovery, that would have to come back to the opioid settlement committee. The reason is because that would change the percentage and the dollar amount. So that is, and that has not happened. We haven't had to make any of those type of changes. But if it did, that is when we would go to leadership, have the conversation with level 1, and then probably get guidance from the secretary and then come back here talking to Brandon. So.
Are we level 1?
You're level 1. You are like above level 1.
That's within a specific program?
It's if money would be moved from one pillar to another because.
Within a specific program or within just the pillars at this level? Not on an agency level, but on the committee level, right? Where does the request generate from the program itself?
The state.
From the state, okay.
State agencies.
Okay.
Yeah. Because we can't change, that's legal, like it's in a contract. They have to, but it's when, for instance, I'm trying to think of one, like we do get requests, but so say a program is, has extra money that wasn't spent and they have another program that could use that additional money. I'll give you an example, and I'm not going to say the name of the agency, but there was an agency that kind of decided that they were going to put their money back, that they were going to move in a different direction. And so as state agencies, that would not be opioid settlement committee's role in this because this is state agency level. In order to be able to meet the needs of the state for that, what we did was it was the Department of Health, eohhs, the Department of Health came together, we worked together, and then we kind of looked at the situation and we reallocated money from one vendor to another vendor because they were already doing the work. We just had to expand them beyond that to cover that gap. And that would go through the process. There's a form. The agency would put it together, we'll have a conversation, and then it has to be approved.
Question? Yeah, Nadine?
I mean, just to kind of, like, not to beat a dead horse, but just to go back on the supplementation point, and in light of kind of what Kathy has demonstrated here, I mean, that is really the first, that the budget proposal that is submitted and originates from the governor's office will be the first indication of whether there is supplementation, because we ought to be able to tell year after year where the funding, what the funding is coming from, right? Like Rhode has certain line items, certain budget asks, leaving aside settlement and stewardship fund that go towards some of these programs. Same with Buddha, same with maybe other state agencies. And so presumably in the budget that comes out of the governor's office, ultimately, you can tell whether that is going to be level funded. I'm not talking about federal funding over which we have no control, and I completely agree with Dr. Chan, like that is just outside the scope of what we can deal with. But non-federal funding, that state funding that goes to these programs, we ought to be able to tell that has, what's happening with it. Does it stay the same? Does it change over time? And again, there may be reasons why it has to change over time. I mean, we just have to be realistic. It's not something that we should strive for and want to do, and we should counsel against it, but that's just, I think, the issue we're trying to deal with.
And I think that's what Kathy's getting at, right? Is
Right.
wanted to explain that there is an intensive process to identify these issues and bring them to the committee, particularly if there was a desire to shift some of the previously approved allocations by pillar. So we just wanted to make you all aware of that existing oversight process and your role in that.
And I think it's what the most important thing, and the team here at eohhs and with Brandon as our chair, we really thought about, the questions that you all asked. I want to be mindful that, we want you to have the tools that you need and the information that you need. We're in this every day. We know this like the back of our heads, we're in it all day, but being mindful that not all of you have full-time jobs besides this, right? To give you enough information, but also to make sure that you feel comfortable as stewards in making decisions and voting.
Okay, so just due to time, I wanted to move us to a review of the process, then we'll do our first public comment and then go to the budget information. So if you go to the next slide, so just to review where we are today and the process for this committee particularly, there is an input gathering process from members of the task force, particularly its various work groups, conversations with community members, state agencies, and public input that happens mostly in the spring and at every one of these meetings. We heard in May a synthesis and report out of the task force feedback from Kathy to help you think about where the priorities are currently bubbling up in terms of addressing the overdose crisis in the state. And then in June, we saw a review of the data, right? So if you recall, Rhode representatives presented where we are with the data to provide that additional context as well, in addition to agency presentations highlighting opioid settlement funded programs, progress to date, and so on. That was led by Kathy, Tamara, and others. Today, where we are today, is providing you with a proposal for fiscal year 2027 and giving you an update of where we are on spending to date and getting your feedback on this proposal. We can continue that conversation in August. Part of today as well is hearing from you on what other information you need to feel comfortable and confident with a vote in August. So when we get to the discussion, please let us know what information you may need to move us towards a formal vote at our next meeting at the end of August. So that is the process. Before we get to more of the budgetary information, I did want to pause for public comment, just recognizing feedback from the community that's sitting for the entire meeting is not always accessible and equitable. So we are going to try our best to have 2 public comment periods. So we're going to move to the first one now, and then we'll move to Michelle's presentation. So as a reminder, please try to keep your comments brief, 2 minutes ideally, so we can get through everyone. We will have a second public comment period at the end of the meeting if you'd like to react to more of the budget information and proposals that you'll see later in the meeting. So let's go to public comment. We'll start with members in person, members of the public in person, and then move to Zoom. Yes. Hi, Linda.
Hi. I don't mean to be disrespectful. My knee hurts today, so I just can't stand, okay? My name is Linda Hurley. I'm the president and CEO of Kodak, and you guys can hear me? Yeah, okay, thank you. First off, I really want to thank you for the opportunity. Deputy Hall, thank you for that request as well, to have the opportunity to speak twice during the 2-hour period in order for people to have a more relevant response to the conversation as it develops. And also for the opportunity to put something online and really get a conversation going. That's very exciting to me, so thank you, and thank you everybody. And thanks for all, this is beautiful. I just have one comment. And again, this has reinforced for me the importance of the Governor's Overdose Task Force in providing an advisory council to this group. And again, I just have to say, and I'll give you an example, that generally speaking, when we're on the meetings, and I know the number of people that are on the subgroups of the Governor's Overdose Prevention Task Force, you're still looking at about 140 to 200 people tops. And Kathy, you had referenced there was a listserv with 2,000 people. I'm on a bunch of listservs, and I can't even begin to touch all the things. I can't read them. That's not a real number to me. So if we have a way to, when we said, first the task force and the work groups, of course that's important. And the state agencies, of course that's remarkably important. But I don't even know where the community conversations and the public input was. As I said last month, there's 10,000 people just getting methadone and buprenorphine in the state. And they all have people that care about them. Most of them have employers. So you're looking at easily 50,000 people in the state that we are probably not strategically reaching. And that's been one of, in order for you guys, for you as this council to get all the information that's important. So there you have it. Is that 2 minutes?
Thanks, Linda. That is. Thank you.
Okay.
Appreciate it. Any other public comments in person? And we can move to the Zoom.
I don't see any.
And Linda's comment reminded me actually of our comment form and the email address, which is live. We review that, the team reviews that on a bi-weekly basis, and we committed to reporting back on what we had received over the last month. We didn't receive any comments in the form over the last month. The emails that were received were exclusively logistical and technical in nature, changing email addresses, things like that. But again, we really encourage people to use that form and email address as another way to engage with all of you and the state agency staff. Kathy, did you want to react to any comment about the community conversations or the other input processes?
I just want to say that I want to acknowledge you've said it a couple of times, and I heard you loud and clear as far as trying to reach the community more beyond the task force, and that will definitely be, you know, front and center. What we did do in the immediate response to that was we developed a form so that at least it's accessible by email. But not everybody has access to email. So I heard you, and my thoughts are bubbling. So I think that I have some ideas and some thoughts that I'll talk to Brandon and the team, and we can continue to talk to you all about that as well.
Can I ask you a question if I can count myself as a member of the public as well? Is there a public-facing archive of our work that people could access? And
Yes.
look at stuff?
Yes, so just as a reminder, and
Get an email to me all the time.
too,
I know
since we're
it's
talking about the public, thank you. We actually, on eohhs.ri.gov website, we have a opioid settlement page. So all of the presentations and the materials are on that page. In addition to that, as you saw, it was brief, but you saw, we have a settlement page on Prevent Overdose RI that has the specific, you know, links that'll bring you back to the eohhs page. In addition to that, we have a task force page, we have all the work group pages, we have lots and lots of information. So Prevent Overdose RI is really the main place for all things overdose for the state, but there is also, in addition to that, an eohhs opioid settlement page. And we work very closely also with the Attorney General's office to just make sure that we keep things updated as far as revenue and budgetary stuff.
Thanks.
I have a quick comment.
Sure.
I know we're pressed for time, but would it be outside our purview to incentivize awardees of this settlement funds to obligate, you know, the work or contacting back up to the Opioid Settlement Advisory Committee or the task force? Could that be
They
something
present at the task force on a regular basis. We do it by pill. Is that what you mean, to present some of the work they're doing?
Well, no, not just to garner on additional feedback and comments from the community, like the awardees, if that's something that we could possibly do. So each awardee that we get, maybe we can incentivize them with some, I don't know, monetary, whatever, just to, you know, to talk to the population, the public, and get additional feedback.
Great idea. Love it.
It's a great idea.
Love it.
Thank you all. So I'd like to move us now to Michelle's presentation. I'd like to invite Michelle to come up and give us a review of where we are to date in terms of the allocations and spending so far. Yeah, go ahead. Thanks, Michelle. Take it away.
Hi, welcome. I'm Michelle Goncalo. I'll introduce myself again, the finance manager for all opioid funding. And on this slide, next slide. So this slide represents all of the dollar figures for state fiscal years 23 to 25. As you can see in the dark green, we have the total allocations from FY23 through 25. And that is about over $48 million. And in the light green, and this is as of 7/7 only, we have an estimated of $25.4 million spent. So our fiscal closing has not been completed for For June, we're still in process, and the state also received, well, we are in a new state financial system, so as of 7/1, so the process is going to be a little slower to close this year for FY '25. So you have an update of spend through 7/7, and this is things that were paid and processed in our current system, which was Ride So there will be more updates. So next meeting, we can have more of an update into how much spent. So as you can see, it has increased substantially in the last 2 years of spent, 24 and 25, with each being over $10 million each, which is over like 52% spending thus far. So reminder to all that last month you've heard from agencies where they provided some procurement updates and they're in their planning, and for instance, like treatment appears to be like a lower percentage spent because of the fact procurements that are now live now, and there's other reasons to that behind too, especially with a lot of it is braided funding with federal, and federal is, they have their rules where it is spent first versus like restricted like settlement dollars. So of course, federal will be spent first, and that's why our percentages are lower. What else do I have here? And then in addition, I'd like to say some of the settlement funding projects are expansions of existing initiatives and are braided with federal funding, as I mentioned. So some federal contracts do not always allow funding to be carried forward, as you all know. So they spend first for federal and then restricted receipts for opioid. Any other questions?
Yes.
So is there any way to present this information with maybe an overlay of the other funding that's allocated to these pillars? Which Kathy's laughing because I'm like a broken record. I ask for this, not at every meeting, every month, which is like, okay, federal funds that are going to these same programs and other state funds that are going to these same programs.
So state funds, it's not as difficult. Federal funds, it's a little bit more tricky because of Medicaid, because remember, treatment is almost all Medicaid reimbursable. The good news is, and I know Tara and I had talked about this, we just didn't want to send it out and then confuse you all a little bit. The OMB actually had a substance use disorder survey that we did for FY '23. It wouldn't have shown a lot of the settlement stuff, and my understanding is they are about to do that survey again with the agencies, and that will get you what you're looking for. On a regular basis, we do at eohhs, in my role as for the task force under the executive order, it basically, that's my responsibility, is to sort of staff it and do the interagency whole of government approach. We do work with the other agencies, and we do take under consideration when we're doing budgeting for that, but to have a full line of sight of every single dollar of federal funding, we don't have that mechanism, but we are working on that survey again with OMB. So we'll have something through FY '25 this time.
I mean, I appreciate that, Kathy, but again, like every year there's a budget and we know, let's just focus on the state and we know where the state money is going.
Yeah.
Okay, we have $5 million, again, leaving aside the settlement funds, which are very well represented here and documented here. We have the stewardship funds. We know how those are used. We have other state money. We know how that's used. We ought to know how that's used. It's like in the budget every year. Why don't we cannot make these decisions in a vacuum, which is what I've said meeting after meeting. So we need to know what the other funding is, what the other funding streams are from the state that go to this. Likewise with the federal money. Now you're talking about Medicaid, maybe Medicare, that are like rate reimbursements. Understand that those are, that's somewhat slightly different, but there's still like no reason why that can't be presented to the committee as here's the amount of money that has gone to, for instance, treatment provider in the form of rates, for MAT or whatever, treatment, whatever. I just think that having the context of the universe of spending is going to be very instructive.
So I will, as a follow-up, I'll send the SUD survey. It might not give you what you're looking for, but let me look at it. And I don't disagree with you. And we do, that projection, the presentation that I showed you of some of the work that we do on a interagency level, we do, when I sent that request out for projections and I sent where are we are asking for federal as well in that. And it's by grants and it's so different. The grants, the fiscal year is different and all of that. And I'm not in any way disagreeing with you. I absolutely agree.
Yeah.
That's what my role really is to make sure that there aren't any cliffs based on federal funding.
Yes.
Brenda, on that topic, is the challenge to try to classify the state money in these 6 buckets?
No, that's not the issue.
That's not a challenge.
No.
So you, from looking at the state budget and agencies, you can actually easily identify how many state dollars are going to recovery, treatment, harm reduction.
We have a handle on the state dollars. It's the federal dollars that we would need the state agencies to give us that information so that we can overlay it.
Most of the federal dollars, aside from grants directly to providers, come through a state agency.
Yes.
So they could probably break that down for you.
We could get that information from the state agencies. I put a request out every year with the project that, so what usually comes back is the settlement dollars and the stewardship. I don't always get all of the federal information. So we can talk about it in our level 1 and maybe we can make that happen.
Yeah, because I thought the challenge was trying to figure out where some of this, how the state dollars fit into these buckets. But if
That's
isn't,
not,
then.
it wasn't when we did the SUD survey and we used the pillars for that.
Well, the SUD survey just doesn't break it down by buckets.
Yes, it does. We helped to create it. It
What's the
does,
difference
it's the same
survey?
pillars.
Okay.
Yep.
And this is exactly why we have the meeting and this discussion now, so we have time to put together this information for end of August. Yes, Dr. Chan?
Ask a question about the existing spending. So are the contracts being done by eohhs, are there multi-year contracts?
Yes.
So if the money is allocated in 2024, let's say for 2 years, then theoretically an organization could be under contract for 2025, 2026, and that money would show up here.
Well, this is only allocated through FY '25. So we have, if it's already in a contract, those allocations is already in '26.
Can you repeat that question and I'll try to help you.
So let's say, so some of the money that we're getting out is to organizations for multi-year contracts. So it may be, let's even number, $1 million for 2025, $1 million for 2026. So when we look at this and we see the amount allocated for 2025, is there already money allocated for 2026?
Yes, that's what was voted on last year. So right now we have a total of $20,700,000.
But in this is only allocations for. This is only allocations for 23 and 25. This doesn't have any, like, this is like looking at the allocations, not so much the contract, because you can't have a contract into a next fiscal year. You would have to break it out into another table. Like, purchasing can't do that. You know what I mean? Does that make sense?
Yes, so okay. So we're gonna talk about fiscal year 27. So is there money that's already been allocated under contract for 27? Are there any contracts that extend to 27?
No, I don't believe so.
No, they can't because we don't have the budget. We don't have the money. But there are contracts that have FY '26 because that's already in the recommended budget.
Right.
Okay. Something that we've discussed before, and I know this may be a slight deviation, but I do agree with AD in general. We've discussed this. Is it worth discussing whether or not we set aside some money and don't allocate yet and kind of either put some money into a separate category of basically a savings account to allocate later? Given that we don't.
We have a thought on that, Phil, so hold that thought.
Will do.
And we'll come back to that on the next slide, actually.
Okay.
Because that is something that we wanted to walk through today. Yeah, yeah. Any other questions for Michelle?
So I just,
Yeah.
I think what Dr. Chan was asking is, okay, this says very clearly, this chart is the money that was allocated and spent for 23 and 25. We've already allocated money for fiscal year 26. But that would just be a separate chart.
It's not in here yet.
That's not in here.
That's right.
Okay,
That's right.
We just started fiscal year 26
Okay.
now.
But I will show you the fiscal year 2026 allocations that were
Yes.
approved in a moment.
Next slide.
Okay, so why don't we do that? Thank you, Michelle.
Yes, you're welcome.
Okay, so let's go to the next slide. This single, there we go. This single slide is where I wanted to spend most of our time today. So there's a lot of information here. I'm going to walk us through it. Do ask questions, and then we'll spend these 20 minutes on the discussion. So this has on the rows the cross-cutting strategies in gray and the pillars in blue. It has information on specific strategies and programs within those buckets shown in that middle column. As Kathy mentioned, this committee doesn't vote on those specific strategies. We vote on the percentages overall by cross-cutting strategy and pillar, but we use many opportunities, including at this meeting, to get feedback on what priorities should be. We've heard from the state agencies, from members of the public on the kinds of strategies that they feel are important. So part of our discussion today can certainly be collecting information for the state on specific intervention strategies within a pillar that you feel we should prioritize, and that can be taken into account as they develop specific RFPs and procurements. Then in the next column, we have the approved, the recommended and approved allocations in fiscal year 2025. Now, this always confuses me for folks not intimate into the state fiscal budget process. Fiscal year 2025 means July 1st, 2024 to June 30th, 2025. Is that correct? So that's that money there. That was a total of 18 million. And how that 18 million was broken down by percentage across strategy and pillar is shown in that column. The most recent allocations, which were recommended by this committee and then approved by the secretary, are shown in that second to last column. So that's fiscal year 2026 that we were just talking about. We just started fiscal year 2026, right? It actually started 3 weeks ago, July 1st, 2025, and goes through June 30th, 2026. What we need to vote on in August is that last column, the percentages that are going to go into effect about this time next year, right? So that is the most important column for us. This is a proposal that EOHH staff put together that we want feedback on today. They developed these proposed percentages based on extensive conversations with all of the state agencies, the needs, the priorities that we heard from members of the public, from the committee, and many other sources of data. Also, at prior committee meetings, we had discussed how making dramatic changes to these percentages could be very disruptive. So one overall framework was to avoid shifting things too much across specific years. The final point I want to make, and this goes back, Phil, to your point, is the overall dollar amount, which we actually have on the next slide, but I'll get to that in a moment. I want to highlight that in fiscal year 2026, this committee voted actually on $11 million. And then later, after they voted on those recommendations, an additional 9 million came in, I think from Walmart, I want to say, as an additional settlement. And the decision was made then to basically add that $9 million in and allocate it proportional to the previously approved pillars. So that's still sort of what was done previously, right? Like additional money as it comes in, this committee can decide what to do with. We can allocate it across the previously approved percentages. We could decide to hold some of it back. So what Kathy and I thought is that we could have that discussion in a special meeting in September or October, because we know additional settlements are coming in, right, from Purdue, specifically the Attorney General mentioned that settlement last meeting, but we do not have the Purdue settlement details in hand yet. So we didn't want to introduce that today because we don't know the specific schedule of that settlement. So currently in hand, in-house today is 10 million for fiscal year 2027. So that's what we're going to be voting on in August, is how we break down that 10 million, knowing though that more money is coming in and that we will discuss later in the fall, or at least that was our proposal. So those are the pieces of information I wanted to convey before we have our discussion. Did I miss anything, Kathy or Michelle?
No.
In this?
The only thing I want to remind everybody is, and Michelle, you can probably speak to this from the back of your head, revenue is going down. It's going to continue to go down.
Yeah.
So that when we do discuss this in October, keep that in mind when we're talking about additional new settlements.
The Purdue settlement is significant. I think it's 30 million.
Yeah.
But the global settlement does go down each year. It does decay
A lot.
a lot.
Well, we got new funds this year, which was the small group manufacturer, that second manufacturer settlement group.
The 3 million.
Yeah.
Yeah, and
Is that figured in the 10 million?
No, and
No.
we're in discussion, so just because it was public, we talked to Julia, and it looks like some of that is also medication.
Okay.
So it's not, and that 3 million, what was explained to me, and please share it, because this is, that's only 80% of what comes to the state. The other 20 goes to municipalities. So you minus that out, and then there's also medication option in there. And if we don't take the medication, then it's only a percentage of the 3 million. So we're trying to work through that, and Julia.
That's fine. I just wanted to know if that was part of this.
Yeah, that's not.
Okay.
Okay, so let's open this up. Yes.
Wonderful. Thank you for presenting. A couple comments. I remember sitting here a year ago, and to Addie's point, we're talking about the need for some data to inform these decisions. So I think it would be helpful at some point to prioritize or get some data, not just on the dashboard, which looks phenomenal, and we've seen a 19% decrease, but specifically the impact of the OSAC dollars and how those have affected the outcomes. I think that's kind of a missing link, and maybe folks are working on that. But I've been trying to think for the last few months how to wrap my head around, we're supposed to sort of allocate some of these dollars, and it's so tough to do thinking about 2027. I think one key piece of data that may be helpful would be thinking about what percentage of these dollars are going to sustaining existing efforts and what percentage are going to new efforts. Yeah. So I think if we understood what percentage, there's a lot of programs we want to sustain, but I think I would almost argue that we want to hold on funding and allocating money for new programs, like new programs for treatment, because 2027, we don't know where that's going to be. I would almost suggest that we think about holding some of that back into the savings account somehow, whatever mechanism, and sort of thinking about this as what is the bare minimum we need to sustain our existing programs versus starting new efforts, and understanding a little bit when we think about, the 27%, the 12%, et cetera, what percent of that is just sustaining versus new?
So I can do that for you, and I actually drafted it, and then I said, well, why don't we just wait? And I should have just done it. I drafted because it was exactly what I was thinking, and I actually drafted it and tried to align it. It was just a lot of information, so I think for the next meeting, I can have that ready to show you what's sustainable. I can tell you from the conversations with the state agencies, this is a $10 million, over $10 million reduction, I can all of this is actually reducing, and maybe if we move to the next slide and we show the dollar amounts, this is a reduction, a pretty significant dollar amount reduction. And to be honest with you, I'm saying this off the top of my head because I started doing this, but I'm so in the weeds of it. Every single thing is to sustain. There isn't one thing that's new in here. It's literally to sustain. I don't see anything in here that's not for that. I think you're right, Dr. Chan, but I think the issue is it's $10.7 million less. I think that conversation might be good for the newer settlements that are coming in now. Mm-hmm. That's up to you all though.
Yeah.
But I'll give you that information in the next month, for sure.
Okay. Treasurer, and then here.
One question, possibly two. How are the fund, what percentages, how did you determine the percentage of allocation? Was that based on a formula of spent, unspent, or is there a need determined there? Was there, and if things were, if it all, almost all is going to sustainability, were there things not sustained that by this allocation?
Well, so we worked with the state agencies. That's why I know the process was very broad. If I gave you the more detailed information on the process, it was really working with the agencies and looking at the budgets year over year. Michelle, feel free to chime in as well. We looked at the budgets from the year before and we just literally level funded it. The ones that are sustained, that are already happening and that are doing well. To Dr. Jan's point, and to answer your question, I know, I'm just saying from what we've heard from our evaluators at URI, to be able to determine and go to compare whether it's because of settlement money or because of federal money, it's not. It would be a very difficult task to do, or to compare program to program would be an impossible task to do because it's about the continuum. But to get to the point of your question, Director Leclerc, this is literally looking at last year's budget. We're actually looking at a minimal budget of $10 million. What we did do is last year, when you all looked at 11 million and voted, that was only sustaining the existing programs. There weren't any new programs in there either. What we did was we used that as a guide for the agencies, and then they came back with their recommendations.
Okay, follow-up question then. So looking at the information you presented, we have about 24 million allocated but not spent. This 10 million adds to that, so we will have 34 million that available for spend next fiscal year.
Correct, and the funds carry forward year to year.
But that 24.5 million is not, it hasn't closed yet, so there's still invoices.
It could be more, right?
Yeah. There'll be more spent.
There'll be more spent as soon as June is closed. Hope to have
Yeah.
a more updated number yet next year.
Yeah, I know. Okay, but roughly there's an amount that's unspent.
That's right.
That this would be, 10 million would be added to it. So if we're, as an example, we're looking at an additional 500,000 for social determinants of health, that 500,000 would get added to the unspent amount of about $4.7 million for that particular bucket. Is that the right, am I doing the right math?
Yeah, I mean, we can't tell what the unspent for FY26 will be yet, but we'll know what the unspent for FY25 will be. Then it goes, and it was such a significant amount in FY26. What I've told the agencies and what we've talked about is try to make that FY26 money stretch as far as possible for the programs that there's just not enough money in FY27. The example for social determinants of health, for that one, it was basic needs. That's where basic needs is, and that is a sustainability of existing basic needs money that is going to some of our contractor partners. I just happen to know off the top of my head what it is. And then a very small amount for sub-homelessness. But actually, it's only the homelessness initiatives, yeah. So there isn't much there. I actually would have to look, but Dr. Kim has it.
Yeah, just going back, sorry, to the evaluation data, I appreciate your comments about, it's really hard to look at distal outcomes. I wonder though what would be helpful. I mean, I'm still waiting a little bit for some organizational level data on this. I wonder if it would be possible under a given pillar, we can just say harm reduction, to have where the money was spent in a fiscal year, what organization got it. And we all chose the dashboard metrics because they're sort of intermediate markers to the end goal. So for example, if we gave an organization, $1 million in fiscal year 25, and they distributed 100 Narcan kits, I think we want to revisit whether we should give them $1 million, right, in 2026. So that may be a way to sort of get at just seeing loosely, like how many, what the money is funding based on the dashboard measures, and to see if the money is frankly being wisely spent, because I think that's one of our tasks, right, is making sure that we're spending X, that it's contributing at least to those intermediate markers that we measured. What do people think about that? Is that a kind of a way to get at?
Can jump in here and then maybe we'll rely on Kathy, Phil. We recirculated the report of all the funded programs. So we didn't want to put that in a slide today, but we can do that. So we can all see, and it is publicly available information, all of the funded entities and how much money they've received. So I think that should be possible. I would encourage us this committee's role is not to have oversight over specific programs, right? So the agencies do that. They're in contract with, say, a specific organization, and they're monitoring whether they're meeting those deliverables that were laid out in that contract. So I would not encourage us to get down into the weeds to that level. This committee, though, is trying to determine collectively, are these initiatives within that program achieving the overall goal of those metrics that you mentioned? So I think that is the way that we should be thinking about it as a body. Collectively, do the organizations that were funded under harm reduction, are they collectively moving a metric in the goal, in the direction we want? Does that make, I just wanted to clarify sort of the different roles for the agencies and the committee, and please correct me if I'm wrong, and Rep. Hall, over to you.
Safe to say to go to Kathy for the additional information that we may need.
I do want to say that I couldn't do any of this without the team.
Yeah.
We have our data analytics lead here. And I just want to say that out loud because I know I do a lot of the talking, but our team is here and like I'm giving Chris the eyeballs and then I'm looking back at Tamara, the evaluator, and so thank you for setting up, but I want to say that out loud.
But because I can understand what Dr. Chan is saying.
I do
and
too.
what he's getting at. But and I can understand what you're saying, that we don't really need to, if someone's already doing it, but they get the answers, that's all I'm saying.
I think that the presentation from the state agencies, maybe we can really continue to do that. That's what the last meeting, rather than Kathy be the one to present the programs, I can't take credit because I gave credit to eohhs, but I need to also acknowledge the Department of Health, and BHDDH and even, some of our other agencies and also the community partners, that they do so much of, they're the ones doing this work. I'm just behind a big spreadsheet on a regular basis, memorizing it all. But maybe that is something to, maybe we could get more feedback on what would you like to see in addition to what you heard from the agencies last month. That could be something that could be helpful.
Yeah, Julie, and then Aditi.
I don't remember when this meeting was, but I remember we had a meeting where we were introduced to the professors at URI, right, that were doing the evaluation work, and that's what I thought was going to plug this hole in terms of our analysis of, and we talked about the pillars, as I recall, and we talked about how their work was going to tie all of this together so that we could have a clearer picture. So where does that work fit in with all of this? And are we going to be seeing, a report or some analysis from that group that I thought, was meant to kind of answer some of these questions?
Yeah, we're currently working, we've taken a priority approach. So we're currently phasing it, starting with prevention, and then simultaneously working on the other priorities. So things have been pushed out, but we can definitely, I know we've been talking about having them come to present this fall to give an update and progress on what you're looking for.
So what is the timeline? So they're just looking at prevention right now.
Correct.
It sounds like. And when were they engaged to do this work?
The contract has been over a year.
Okay. So what's been the hold, like the delay in some of the work?
I mean, it's just taken some time to get the information gathering. So that was about a number of months. And just we're working on documents that we can definitely provide you with updates and reports, and we haven't been doing that regularly. So I think
So there is a logic model that was already drafted. It's still in draft form for the overarching strategies. So they're actually looking at the overarching overdose work, not just opioid overdose, not just opioid settlement. And what they're doing right now, it's the process of really just kind of looking at, the indicators. It's also important to remember that URI is looking at the evaluation, but one of the things that has happened since I took this role is we did a strategic refresh of the strategic plan, which was absolutely necessary because I didn't even realize that there was an action plan, an evidence update, there was priorities of OSAC, there was priorities of the work groups. We consolidated, deduplicated, went out and got community engagement for all of that. And we also did the same thing for the indicators. So the reason why they're focused on prevention is because prevention has multiple different strategies, and the one thing that we keep on looking at is student assistance counselors, rightfully so, very important because it's being funded by settlement, but there's a lot more happening in prevention than just the student assistance counselors. We're also funding community-based through opioid settlement. There's also other programs and other indicators that we want to try to have a broad indicator on prevention. That's the reason they're focused on prevention, but we have indicators for all of the other pillars that have been agreed upon. And they're there. So that's to your point. It's not at the program level, Dr. Chan, but it's the indicators, which as leadership you reviewed with us last year and gave feedback, and thank you very much. Following the governance process that I told you all about, and we came up with indicators across the pillars. And that really is all has to do with all of the state agencies in the community giving input so that we can measure and see, are we moving in the right direction to reduce fatal overdoses and also improve people's lives to the overarching goal. So it already exists. Prevention just happens to be the one pillar that we're working a little bit more closely on.
I have a question, which agency is in charge for prevention? Which agency is in charge of who department?
The HDDH. Behavioral Health, Developmental Disabilities and Hospitals, the department.
All right. If I want to work with them more closely, I can go and contact them?
Yeah.
There's also a prevention strategy work group. If you're interested, it's tomorrow. That would be a great work group because URI is actually going there to present tomorrow.
Oh, okay, great.
To get input.
So I think,
Adi, yeah?
oh, I'm sorry, did I cut somebody else off?
I don't think so.
Okay.
No.
I just, again, to just go back, I think what we're all trying to get at, what like Julie and Phil are trying to get at, and me, is the level of granularity that will be helpful to the committee. So this is not granular, right? This is like 100,000 feet up, which is helpful, but, and I totally agree with you, Brandon, we don't need to be at the, 10 feet up. But we do need to be at the maybe, 1,000 feet up, where we can tell generally, okay, prevention, X percentage of dollars, or this number of dollars are going to funding school counselors. There are 50 of them, or that was the intent, was to fund 50. That has been met. I mean, it's oversimplification to somewhat. But, last meeting, I don't know when is the good time to bring this up, but last meeting we heard a lot of really good information about needs, treatment needs that have not yet been achieved, like goals, right? On-demand treatment. There's still like a waiting list. I think one of the issues that was raised at the last meeting was detox or treatment for pregnant women. I think one of them was like treatment for adolescents. So we've heard like very specific information at the last meeting about particular needs that were fairly concrete. And those things are measured, very easily measured, right? So like the number of people on waiting lists for treatment, that is something that can be measured. And for me, I think that would be very helpful and very important to know when making these future allocations. So it can't just be that we're applying a formula, trying to just like replicate prior spending. Keeping in mind that, yes, sustainability is a goal, but I also think none of us want to spend money on things that may not be as effective or perhaps as critical as some of these other needs that we've heard about. And we just need to have a level of granularity that will help us do that. And I feel badly that Kathy's, well, I think you're here as the recipient of the information and the feedback. It is not meant to be, I don't think by any members of this committee as like a criticism, just you're the recipient of the feedback.
I try to tell Dr. Chan not to go there, but he does.
Okay, we can't help
We'll talk about it
ourselves.
later. No, I make a joke out of it. It's my job. It's okay. We're all here because we want to save lives and we care about people and we care about the community and we're going to get there. So, and I'll just work 80 hours instead of 40.
Yeah. Did you have a question?
No, just a scratch.
Okay.
I just want to, I guess, for my own clarification, Dr. Chan was bringing it up earlier. So aside from that $10 million in SFY 27, so none of those awards in the fiscal year that we're entering, none in the previous years are, I mean, those are getting spent in those years. They're not going to be spent in out years. So
they carry
that
forward.
10 million is it.
No, right, but they carry
for
forward.
SFY 27.
No,
They carry forward.
that is not correct. There is money that
Okay.
will be available for SY 27 beyond this money,
But it's
because there's a lot of unspent money.
But it's
Yeah,
allocated.
It's allocated.
So
This is just allocation.
decide about where to spend
Correct.
that money, but it's there for spending
Right.
in the allocated buckets.
So going back to
This is decisions.
Director Leclerc,
Yeah.
please feel free to explain the example that you gave. Director Leclerc had said, so what you're saying is $20.7 million in FY 20. Well, he was, actually, we're in FY 25. We had $18 million. Not all of that 18 million was spent. That will then get added to the budget as, what do we call it, Michelle? What's the correct? Carry forward, but what is it called, which budget?
Oh, the governor's revised.
Yeah, so Michelle always gives me the right terminology. The governor's revised budget will add the unspent from FY 25 into FY 26. So FY 26 budget will be more than the 20 million allocation, and then so on. It'll go to the same 20.7.
It will be based on whatever allocation model we determine, the new percentages, I guess, it carries into those.
That's right.
I guess I just was under the impression that some of this work was multi-year work, multi-year
It is.
contract, right?
Some of it is.
Okay. So I guess I'm just gonna use, I don't know, I'll use, Linda was right behind me. So so Kodak is a 3-year grant, right? That goes into, that would carry into SFY 27 and SFY 28. Is it gonna be accounted for? I mean, how can we see that? How can I visualize that there are allocations that have been made that carry forward this work and juxtapose that to the decisions that you're gonna be asking me to make in a month? Is there a way to see that?
You're asking me.
Am I asking a stupid question?
No, it's a good question.
Great question.
I want to give you an example. So for example, I'll give.
No, but Kathy, can you can you answer Senator's question? Because I think what you're saying is that money.
I'll use JA.
That
Let's say
Kathy,
JA.
but the Kodak that has been previously allocated to them is not part of this 10.7 million.
I think that's important to know, just because I don't know
So
whether to
in
see
deciding this, you
the
want
10 million
to
as
know what
like,
happened before.
holy smokes, we're gonna be cut, we're gonna be cut in half, or, okay, well, it's less new money, but at least to treat it as new money, so to
So
speak.
that's how we see
There's
the
other work
decisions.
that's going on underneath the
So
surface. that's
to
gonna
answer your
continue.
question, I'll give you an example of, like URI is our centralized naloxone hub. We get free naloxone from the Teva settlement, thank you to the Attorney General's office for that, because that saves us a lot of money. We get 50,000 kids of free naloxone every year for 10 years, I think it is. I think we're into year 3. right? So we also have to pay for URI to be the distribution center for that. So every time that we give you these percentages for FY 26, 25, 26, 27, that's accounted for in there because we know that has to be sustained because it is the hub for all things naloxone in the state. So in other words, when we meet with the agencies, the URI contract, the mobile outreach teams, that's who's distributing it, making sure that we have those infrastructures in place are part of that number that you see right there.
Sorry, so,
That's how we come up with the
sorry,
number.
what bucket does that fall into?
Harm reduction.
That's harm reduction.
Yep.
Which is 2.75 million in the upcoming year. How much does URI get?
Off the top of my head.
Say it's 500,000. Would the
Yep.
500,000 be included in the 2.75 I'm seeing, or is it separate and
Yes.
apart from the two?
No, it's included.
Okay.
That's how it's determined.
It's just fixed.
Yeah, so to try to summarize, and correct me if I'm
And
wrong,
you can't
Kathy,
fix
but
it
the multi-year contracts do
Yes.
gobble up, for lack of a better term,
Yes.
some of these.
So is there a way for me to see, and I'm sorry, is there a way for me to see the multi-year contracts that have been entered into, what percentage, or not even what the raw dollar amount, that 2.75 that's already gobbled up?
So if you, I think because this was presented to you, not this last time, there was last month, we gave you the updates of the programs, and that gave you kind of like what they're doing, and it gave you the overall dollar amount, so you should see that. That gives you the overall dollar amount. It's not, giving you all the details of the contract. That would help. Also, we have an annual report that we give to the General Assembly every year that breaks out the entire table and the budget. For next month, and before next month, because it actually wouldn't be that difficult, Michelle and I can put together the budget, like an updated annual report with the budget detailing all of I think there's about almost 50 different initiatives. That doesn't count all the contracts. It's not broken down by contract.
Are there any areas where we're already overextended and overcontracted?
I'm sorry?
Are there any areas where we're already overextended or overcontracted? Because you're looking at a 50% reduction, right? So, I don't know,
We're not over contracted, no. If we are, there's gonna be areas that are not gonna get funding this year. In FY 27, that the agencies are gonna have to find out another way to pay for some of those initiatives. Because there's not enough money.
We may want to know that. So what's
Yeah.
not being sustained?
Yeah.
They're specific programs though.
Right.
And I think that Brandon, you had said this earlier, these are very specific programs that are under the pillars. And we will have the agencies are more than welcome to come and present or talk about some of the ones. If it's a priority, if there's not enough money, then I don't really know how we could fund it,
What about the money that's not spent in the course of that year?
It's a good question. I can tell you that if it's not obligated and it's not in a contract, we are talking to the agencies and saying that we're gonna have to put it back at the top of that. That's what the budget request process includes, that as well. If it's not spent and it's in contract, then it's in contract. But if it's obligated, and it's like an RFP, we need, we'll honor that, we have to, because they're gonna be awards. But if it isn't, and there's no plans for it, then, that has to go back to the top. And that's not part of this, that is not included in here.
About 20 minutes left. Do you want to move us along? Because we have another public comment and one last brief presentation, but
Okay, so I just want to make sure that I am clear with
Yeah.
your answer to Senator Basilian's question. So some of the $10 million for fiscal year 27 is already obligated.
Yes, all of it.
All of it is.
Yes.
So what are we voting on?
It's either under contract, obligated is a different word than contract. It's either obligated for the infrastructure the Department of Health presented surveillance and labs. It's obligated to continue with that infrastructure. It's obligated because we're in contract with URI, for instance, and in order for us to do a contract modification, it may not be in contract yet because the money, we don't have a budget for it, so we can't put money into a contract that doesn't exist. It'll be, the words of like, can expand for 3 more years.
So all this money's already obligated?
There's not anything in there off the top of my head that I can say, because this is $10 million less. So when we went over this with the agencies, this is bare minimum to sustain programs and to, continue with what we're doing. And they have been reduced, most of them, some of them.
Well, just to clarify, it's not contractually obligated, though. Maybe at the next meeting, we could break up any multi-year contracts that are actually written.
Do that.
So I just wanted to clarify that this would essentially plan to sustain, right? Everything that's going on currently. And only a portion of that would be already written into multi-year contracts. And I don't know, we could find out how many go into fiscal year 2027, Michelle, maybe not many, or you said
They're
maybe
not
0?
Into 27.
Yeah, so does that help clarify? Very little of this would be currently contractually obligated.
But it is obligated.
It's obligated.
It is obligated.
Right.
Yes, I mean, I think what I'm hearing is that some of this money is obligated for like core things that we want to keep doing, right? So from a health department perspective, like I would advocate, we need to continue collecting data, right? And we need to continue distributing naloxone. Some of this money is being used for pilot projects and things that were not meant to necessarily be sustainable. So I think what would be helpful would be maybe to look at where all the money's going, really kind of almost prioritize, put a stamp against like, health department lab funding. I mean, we need to do that, right? We need to collect the data. But what is pilot projects? What is not meant to be sustainable? Or I think what we're getting at too is like, some of these things that we wanted to fund for a year and see what happened and then continue to decide whether or not to fund them because some of them may be, wildly successful for whatever reason. So I think we want some data. I would need to understand a little bit more. I would like to understand a little bit more what is sort of like a core thing that we have to sustain because we have to. What are things that we funded, sort of thinking there were kind of pilot projects that we wanted to look at? And then maybe really look at those and ask for a little bit more granular data, like are they working or are they not? Have them come in front of OSAC. That's sort of my understanding how some of this, I think, would go over time.
So I can give you a report out on all of the initiatives, which is about, I don't know, I think with stewardship, it's like 60. But I can't remember off the top of my head, but it's a lot. So I'll give you that printout like I do for the annual report. I'll work with Michelle. We'll give you the numbers of what the allocation is so that what we're looking at and then the spend. And then I can give you whether it's a pilot project, if it's sustaining infrastructure, and then you'll have that information. That actually isn't that difficult for me to do, except getting the spend amount because it hasn't closed yet. We'll start there and then we can continue the discussion so that I can give you as much as what I have available, okay? And then I'll call you later.
That's a great idea. And there's a third bucket too, I should say, one-time infusion, so the 4.15 million in the treatment infrastructure in fiscal year 2025, that was to, build more residential beds, right? So that's a third bucket that could be categorized as one-time, which, there's none of that in fiscal year 2027, correct, Kathy? So no like one time.
No, it's still treatment infrastructure because treatment is mostly paid by Medicaid, so there's still infrastructure in there. And we want to make sure that we have funds there. And I'm sure Director Leclerc, and I know I'm working very closely with Linda Mahoney, because remember, we don't know what's going to happen on a federal level. And unless there's more questions, that almost might be a great segue for our next conversation.
Yeah, that sounds good. Okay, great. We're running low on time here, folks. So I wanted to move us along. Before we get to the last public comment, just a reminder of how we'll move through the meeting in August. We use this consensus building approach. So throughout the meeting in August, I'll do this basically temperature check to see how people are feeling, and we can make adjustments then. as we move towards the vote. We really do need to vote at the end of August to provide a recommendation to the secretary because it really runs up against the cycle that Kathy previously identified. But keep in mind, we're voting on percentages of the 10 million currently in hand as of today. And then I'd like to suggest that we come back for a special session in September or October, whenever we know more about especially the Purdue settlement and the $3 million settlement, because that can be added, right? So I just want to really caveat the discussion today that this looks like a dramatic reduction, but there are additional supplements coming that we can decide what to do with. But it would just be premature to have that discussion in August because we don't know the exact schedule yet. So we'll vote on the money currently in hand in August, if that makes sense, and come back later in September. Okay.
And I'll bring more information.
Yes, and
I'll
this has
send
been
it
very
beforehand,
helpful.
too.
We have a lot of good feedback to mull over for additional information for you. So it'll be a packed meeting in August. Okay, let's go to the public comment period because we do have one more quick presentation from James, who's been waiting patiently.
Okay. Nice to be back.
Yeah. So let's move into public comment. We'll start, as we usually do, with members of the public in person. Yes.
Hi. No, please. My name is Catherine Diorsi. I'm the founder and CEO of a local nonprofit here called Integrated Healthcare Solutions. So we have lived experience in our organization, but we are also a recipient of the Multiple Pathways grant that was funded out of here, so we're thankful for that. But just one suggestion, I've been to multiple meetings, I've heard about the sustainability, I've heard about the need to change outcomes and really drive those. Just an idea for innovation for you to maybe consider is, we do a lot of program funding, and I've worked off of program funding, and there is that sustainability issue. I think one of the things that impacts every single organization in the state, whether you're a client, a family member, a first responder, a leader in this organization, is whole person wellness, mental, emotional, physical, spiritual, stress, everything that is underneath, which often our traditional healthcare system is not designed to address. So I would really recommend, rather than funding programs, open a new type of innovative center that does not exist in the country. It would be an outpatient, non-clinical, whole person care wellness center that can be utilized for individuals in recovery, family members, first responders that don't want to go into a clinical setting. We've talked to all of them. Also the 18 to 24 age group, it would allow you to go deeper in prevention. It would allow it to go deeper in treatment because it's in combination with all the medications. And at the end, when you work on the underlying causes, that's when you have sustainability because people are actually getting well. Now they have long-term ability to use the center and go out. It could be a Rhode Island-based center, and now they're getting the support. So be long-term, and then you'd see changes in healthcare costs even go down because you're getting down to the root cause. So I just wanted to offer this up as you're looking at all your spending, you're seeing the money go down, and we want to drive outcomes. And I've lost my brother to this, and there's nothing more that I ever would have wanted than to see something like this added in to all the great work that everyone in here is trying to do. So, thank you.
Thank you.
Thank you. If I may?
Yeah.
Is there something that's already established somewhere else in another state or another?
Doesn't exist anywhere in the state, but it's starting to be developed here in Rhode Island, but it needs support. Yeah, and it could be really a great counterbalance too. You've had tremendous innovation with the Overdose Prevention Center. So really you would now have continuum of care from that all the way to a wellness outpatient center to have that to help everybody.
Thank you.
Other public comments? Yes, Linda, go ahead.
I'm sorry, I don't mean to be disrespectful. I'm just old and achy these days. I really do apologize. Linda Hurley, President of Kodak, CEO, thank you for that. We're actually doing something right now that is moving towards that. We're not completely there yet, but we got 20,000 square feet at 45 Royal Little, where we're providing medical, psychiatric, counseling, and addressing the social determinants of care.
We've also opened space up to the Department of Labor and Training. They're there now for career path development, Medicaid. I would love to speak to you, so thank you so much for that. I just want to do a quick, I know that what's important here is the science, honestly, for me, of opioid use disorder. And there is a conference, there's an organization called the American Association for the Treatment of Opioid Use Disorder. It's been around since the late 70s. And I'm part of the national board. Craig Stenning, Mike Rizzi, a lot of other folks from Rhode Island have been instrumental internationally in moving all this forward. And there's a conference, and the conference is October 4th through October 8th. Katie, I saw you wrote that down, so I'm going to give you this. I have a couple of these. I would encourage, I know that we're all busy, but this is really critical. It's every aspect of the science, not just harm reduction, not just recovery, not just treatment. It's every aspect of the science and every aspect of the policy. And so we're going to have some pretty interesting policy and political discussions there. CSAT, Center for Substance Abuse Treatment, everybody's represented. And the board meeting on the Saturday night is open. And it's always been really interesting. I'm sorry, Phil.
Where is it? Is it in
Dr.
front?
Chan, I'm sorry. No, I don't mean to be rude. I'm really just not right today. No, it's in Philadelphia.
Philadelphia, okay.
Yeah. But it is on the East Coast. And if you book it soon enough and you don't go with the Acela, it's pretty inexpensive to get there. Okay.
Thanks, Linda.
And I'm going to leave the webpage is www.aatod.org/ATOD and just conference, and you'll get it. But I'll leave a couple of these on the table if anybody wants to.
That's great, and we can circulate that to the committee members as well.
Yeah, and it was, the founders of utilizing medicine for opioid use disorder are the founders of this organization. So, you look up Rockefeller University and all these really brilliant, caring people that worked so hard in the 50s and 60s and 70s to create the life-saving stuff. They're an integral part of this entire organization, so thank you.
Thank you.
Any other public comments? Great. Okay, we've got one brief update from James before we wrap up today. He's going to be speaking about what UHHS is doing around tracking federal changes, shall we say, and priorities.
Indeed.
Over to you, James.
All right, well, it's wonderful to be here and to see everyone. I know it's been a long time since we started this committee, and I was instrumental in that part, but you all have a mountain of decision-making ahead of you, and I am just going to add to that pile, so forgive me in advance. So we go to the first slide. Awesome. So EOHHS has been doing a variety of things around tracking what is happening federally and how that will impact not just our agency, but many of our other agencies, including HealthSource Rhode Island, the Office of the Health Insurance Commissioner, and others that are in our ancillary world. And we've really been focused on 4 key priorities of doing this. The first is around doing tracking around the policies that are being issued by the federal government. And when I say that, that means it is the executive orders, it is agency directives and guidance, whether that's coming from CMS to Medicaid directors or from FNS to our human services partners around changes that are being directed. And looking in partnership with our national organizations around what are the trends that we're seeing in those spaces to think about how that can help us inform the work that we do. We are tracking that on an individual level of those items, looking at 7 different criteria around severity of what the impacts could be if these become permanent. We are tracking if they are contested or not contested in court, all of these things to continue to give us some situational directionality. And I want to thank the Attorney General's office for continuing to fight to see where these land at the end of the day. So that is one of the areas that we are doing. An example of that is we tracked that, the national Medicaid directors all received a bulletin from CMS saying you no longer shall fund health-related social needs. So it's important for us to be able to bring that to you all to say health-related social needs, housing supports and services, things like medical respite, other things like that are no longer Medicaid eligible in terms of new requests. If it's in your state plan, it's a different story, but as of right now, not an area where we in the HHS side can support. The second area of focus is actually starting next week, and we will make sure to get you the information about the public meeting for the Federal Compliance Advisory Group. And this was put into the state budget where EOHHS has to provide by October 31st a report on the impact analysis of the past federal budget, so the OBBA, including in that potential both pathways for coming into compliance with those and potentially anything else for the General Assembly, the Governor's Office, and others to consider. So that's a public meeting. We have appointed folks by sector, but we again are going to make sure that everyone is on that as an interested party. So we will be ensuring OSAC, Governor's Task Force, our Medicaid Advisory Committee all get notifications of that. It looks like the meeting will be next Tuesday, and again, I will send the details out through Kathy. Examples of what will be included in that are the impacts particularly on Medicaid, which is the biggest focus, also SNAP, which is taking a big hit, and then similarly the tax incentives and other things we had for our health insurance exchange to move people onto that when we did our return to normal operations and Medicaid renewals. So that's the second area of focus. The third is doing program inventories where we are working with the agencies and will be moving forward to inventory all of our programs and what the reach is of those different programs, particularly as we monitor what the fourth item is, changes in federal grants. And so you saw that the rescission package looks like it's moving forward with many of the cuts from DOGE and other things like that. So we'll be monitoring that as appropriations are finalized federally because it's another layer of consideration that has to come in. So those are the things that we're doing. Next slide. And then some potential implications. So as I mentioned, we've been taking these and tracking them and doing some general, I would say very general thematic analysis with our national partners like NASHP and NAMD and others to say what are some buckets and what are some directionality if all of these things were to move forward and pass and become permanent. And so one of the themes is around access, stigma, and vulnerability for specific populations and or other ancillary supports, one specifically around how we continue to respond to the overdose epidemic and treatment specifically for SUD, general system capacity or workforce changes like burnout, additional administrative burden, and other things of that nature that may be placed on us and our partners, and then resilience and equity. So thinking about some of the core areas, whether it's data or other things like that, that could be eroded if certain policies become permanent. While this doesn't give you an answer to anything, it certainly can be taken into consideration with the core principles and guiding principles a committee has agreed to in partnership with Johns Hopkins. A lot of what they recommend are sort of being jeopardized with what this directionality has into play, and you all may want to take that into your thinking and conversations as we move forward. And so this has broad-reaching impacts, and we are looking at it from multiple different perspectives. So to give an example, we want to make sure that things that are prioritized in many of our very public, important plans, we understand what's the impact if in the federal budget, what's the impact if there are grant changes, what's the impact if there's a policy change that says we can or cannot do something. A good example of that is in our Olmstead plan. We recently published our first version of the Olmstead plan, something that relates to behavioral health and mental health, as well as substance use, is the crisis intervention trainings for our first responders and how they respond to emergencies. We know there may be a federal change to what is funded. We know that some of what's here in terms of law enforcement and other authorities might change how things can be responded to, but it is a public priority that was one of the #1 priorities by the community from our disability community for things that we should do. We need to have that conversation about what does that mean for our community partners and what does that mean across our agencies if all of these things move forward and we see changes in both funding and policy. And so that is what we're going to continue to do as EOHHS, It is extremely complex. We are doing the best that we can, and we will continue to come to forums like this as much as we can to provide those updates in addition to the public meetings around these contingency plans that we are developing. And I thought it was appropriate to share that with you all.
Thank you, James.
Thank you.
Not the most positive note to end
No,
on.
I apologize. Not good
Brought
news.
ourselves in, so appreciate all of your hard work and that of everyone at eohhs tracking these efforts. Okay, so we're at time. Just wanted to remind you about our meeting at the end of August, 1 to 3 in this room. Thank you all for your feedback. We collected a lot of good information, which we will try our best to collate and have ready for you to review and react to in advance of the vote. Yeah, Kathy.
The only other thing I wanted to remind everybody, and Carol, keep me honest, I know you're there listening. The Governor's Overdose Task Force next month, it's the second Wednesday of the month. It is going to be focused on the harm reduction and the rescue work groups. And the presentation that is going to be at that task force is going to be the Overdose Prevention Center, which is funded by the allocations from this committee. So if you can make it, it's a virtual meeting. We will be sure we get that information out to you that are here present and also in the chat. And it is on August, I should know these things. I just come to work on Mondays. On August 13th. And it's from 11 to 12:30, virtual.
Can I get a motion to adjourn? No move. Excellent, second. Great, on adjourning, any opposed, abstained? Great, thank you all, this meeting is adjourned. See you at the end of August.